Chronic obstructive pulmonary disease, or just COPD for short, think of the double C's. C for chronic air trapping, resulting in reduced gas exchange due to inflammatory damage to the lungs. And C for CO2 that is high. Patients can't fully breathe out due to the limited airflow and the inability to fully exhale. So we get air trapping and high CO2. Now, COPD is not asthma. The big difference here is that asthma attacks are reversible. They're momentary flare-ups that come and go and usually resolve with age. Now, COPD is irreversible damage to the alveoli and the bronchi of the lungs. That progresses over a number of years, typically caused by smoking. Now, for causes and risk factors, the number one is smoking. This is the number one primary risk factor on the NCLEX and most nursing exams. So the memory trick, just think chronic destruction of the lungs for chronic obstructive pulmonary disease. Now, some other causes are from other long-term exposure to respiratory irritants, like being a car mechanic where we breathe in chemical fumes, or even being a wildland firefighter from that dust and smoke. But again, smoking is considered the number one primary risk factor, secondary to chemical exposures like car mechanics. Now, Kaplan mentions a risk factor for COPD, a client that has smoked for more than 30 years. Now, for the pathophysiology, there are two types of COPD, emphysema and chronic bronchitis, commonly called the pink puffer and blue bloater. So again, think C in COPD as C for chronic air trapping and lung hyperinflation, because air cannot get out of the lungs. So for emphysema or pink puffer, these clients are typically well perfused. They're pink, but they have difficulty breathing. So just think puffer. This results from damage to the alveoli, which results in loss of lung elasticity and loss of inflation of lung tissue due to the loss of surfactant that helps the lungs stretch. So we get a loss of lung tissue recoil and end up with air trapping inside the lungs. And on the other side, for chronic bronchitis, think blue bloater, because they are usually cyanotic, which turns them blue. And this happens due to inflammation of the bronchi, that smooth muscle hypertrophy, and contraction within the bronchi itself, as well as excessive mucus production, resulting in a chronic hacking cough and recurrent infections. Now, in terms of signs and symptoms, for emphysema, think pink puffer. So we use the acronym PINK, P for pink skin and pursed lip breathing. The very earliest sign is that they are huffing and puffing, so just think puffed out cheeks and pursed lips for pink puffer. I is for increased chest, known as a barrel chest. N is for no chronic cough or very minimal cough. And K is for they keep on tripoding to get air exchange. Okay, now for some specific manifestations for your pathophysiology exams. So the manifestations are key signs and symptoms to write down here. We have 4 big test tips. Number 1 is dyspnea at rest, or that shortness of breath. The key term here is at rest. And number 2, a really big one, is weight loss. Be sure to write this down. It's very different from chronic bronchitis and is typically top tested. So remember weight loss for emphysema. And number 3 is prolonged expiration. Basically, longer exhalation or breathing out. And lastly, number 4 is clubbing fingers. That long-term hypoxia leads to vasodilation in the fingernail beds. So please be sure to write that down. Clubbing fingers are those round fingernail beds, which results from vasodilation in the distal fingers due to that chronic hypoxia, that low oxygen. So for the memory trick, think of the O's here. Long-term hypoxia leads to vasodilated fingers, basically clubbing fingers. So distal extremities have decreased perfusion, right? So to compensate, the vessels in the fingers vasodilate, or basically widen, leading to additional blood volume within the fingers, leading to this clubbing round appearance. Now don't get tricked on exams. We're not talking about vasoconstriction here. So just think of the C in constriction as closed vessels, which is not the case in clubbing fingers. So again, please be sure to pause the screen and write down the highlighted ones here, since these are typically the top tested key signs. Now moving on to complications. Advanced emphysema, we see frequent infections, as well as a risk for a pneumothorax due to the rupture of bulbs. So a pulmonary bulb is a small collection of air between the lungs and the outer surface of the lung, the visceral pleura, usually found in the upper lobe of the lung. So when a bulb ruptures, the air escapes into the chest cavity, causing a pneumothorax. Fancy words for air between the lung and the chest cavity, which can result in a collapsed lung. Very deadly. So please be sure to write that down as a complication. And on the other side, for chronic bronchitis, we get that blue bloater. So just use the acronym BLUE. B for big and blue skin, known as cyanosis. This is hypoxia. So just think big and blue. Typically our patients are obese and have a blue body. Now a little side note and a big test tip for your pathophysiology exams. So severe hypoxia, that low oxygen within the blood, leads to polycythemia for compensation or balance. So polycythemia refers to an increase in the number of red blood cells in the body. And here's why. You see, the body is suffering from low oxygen, that hypoxia, right? So the body says, oh snap, I better create more oxygen carriers. So a lot of red blood cells are created to compensate for this low O2. But instead of perfusing the body, these extra RBCs, or red blood cells, cause a huge traffic jam within the blood vessels. Just think about it here. This thick, viscous blood filled with RBCs can easily clog the tiny little blood vessels, forming a deadly blood clot. Specifically, the tiny blood vessels within the brain, causing a deadly stroke, or a CVA, cerebral vascular accident. So this is why we must report any extremely high hemoglobin level. Huge test tip here. L is for long-term chronic cough and sputum. Which cough is the earliest indicator for chronic bronchitis? Okay, now speaking of cough, another pathophysiology test tip here. Episodes of coughing lasting 3 months or longer is a huge test tip, as well as productive cough with thick mucus and purulent secretions, meaning it can vary in color from grayish or yellow to green and even brown. And lastly, the coughing is more severe in the morning, as the body has been sleeping all night and breathing slowly, right? So when a client gets up and changes position, all that thick mucus building up in one place overnight moves around and has to come out with a big old cough. U is for unusual lung sounds. We typically hear crackles and wheezes. And E is for edema that shows up peripherally due to that cor pulmonale, that right-sided heart failure. Now this happens as the right side of the heart is having great difficulty pumping blood into these really hard fibrotic lungs. Eventually this leads to pulmonary hypertension as blood backs up into that right ventricle and then into the entire body, making the body big, bloated, and swollen. Hence the name blue bloater. So the memory trick, just think of R for right-sided heart failure as R for rocks the body with fluid. The key signs is edema, JVD, and weight gain. And a little side note here. For weight gain, just think water gain, as the body gets rocked with fluid from this right-sided heart failure. Now, in terms of vital signs, the big key point here is that decreased oxygen saturation levels are normal and to be expected. So a pulse ox in the low 90% range is normal for patients with COPD. So 88 to 93% is typically the normal range for all clients in worsening or end-stage COPD. So don't freak out and think that it has to be between 95 to 100%. And another classic sign is clubbing fingers, specifically with clients with emphysema. No, not those clubbing fingers, these clubbing fingers. We see round nail beds that sort of look round at the tips here. So this is a common sign of long-term chronic hypoxia. And next is lab values. We see increased blood count, So we have a high RBC level, as the body attempts to compensate for that long-term hypoxia. So don't get tricked here. Anemia is not common with these patients. Many NCLEX questions will try and trick you, so just be careful. Now, in terms of ABGs, our arterial blood gas, this will show low oxygen and high CO2. So again, think C in COPD. As C, the CO2 will be high due to that air trapping, mainly because of chronic destruction of the lungs with chronic obstructive pulmonary disease. That lung scarring and alveoli destruction means oxygen can't get in, and CO2, or carbon dioxide, can't get out. Now the key numbers to know, write this down. Low PaO2 means hypoxemia. So below 80. Normally we want it between 80 to 100. Basically, we don't have enough oxygen in the blood, so think hypoxic for low oxygen means hypoxemia. And high PaCO2 is hypercapnic. The key numbers to know here is a pH less than 7.35, this means acidosis, and a CO2 over 45 also means acidosis. So ABGs will typically show respiratory acidosis in clients with worsening COPD. Now, you might be asking yourself, why the acid though? Well, too much carbon dioxide in the blood leads to too much acid inside the body, putting the body into this acidotic state. So for the memory trick, just think carbon dioxide as carbon diacid, since it pushes the body into respiratory acidosis from decreased gas exchange due to that alveolar destruction. Or you can think CO2 is imprisoned inside the lungs, leading to CO2 crisis, basically an acid crisis. So the memory trick, COPD, just split up the words here. CO2 is a prisoner or imprisoned. So when you see the term hypercapnic or hypercapnia, just think high CO2 for hypercapnic. Now, Hesse mentions partial pressure of carbon dioxide is 65 millimeters of mercury. Okay, wow, that is way over 45. So this patient with bronchitis is experiencing hypercapnia. So again, high CO2 or carbon dioxide for hypercapnia. Now this low O2 and high CO2 can lead to the deadly complication of respiratory failure. So hypoxemic respiratory failure is from that low O2, and hypercapnic respiratory failure is from that high CO2. Now the priority here is for a BiPAP. So the memory trick, just think hypercap, you give a BiPAP. And the number one sign to monitor for is mental status change. So restlessness, decreased LOC, and even confusion. Those three big key terms right there typically show up as the first signs for worsening hypoxia. Now we use a BiPAP for hypercap. So don't let the NCLEX trick you here. We do not use drugs first. So not albuterol, not steroids, and not nebulizer treatment. Not even oxygen here. So you might be asking yourself, why though? Well, think of the patho here. What's the cause? In COPD, we have chronic air trapping from damaged lungs, right? Not asthma here. So a simple albuterol or steroid treatment ain't gonna work here. Many students get this wrong. So write it down. The priority is BiPAP with hypercap to expel that high CO2. Since BiPAP pushes that positive pressure air deep into the lungs in order to push oxygen in and push that CO2 out. Talk about forceful gas exchange, right? You see, the other interventions won't do that. And by simply giving more and more oxygen, this isn't good. This can actually knock out the respiratory drive of a COPD patient, resulting in worse oxygenation and higher CO2, worsening that hypercapnic respiratory failure. And the drugs here only dilate the lungs. There's no high pressure forcing that gas exchange. So again, if the patient is hypercappy, then give a BiPAPy. Or in fancier terms, if the patient is hypercapnic, then give a BiPAP. So a common priority-based question here. An elderly client with worsening COPD presents to the emergency department with fatigue and altered level of consciousness. Big key term there. Upon assessment, the nurse finds an oxygen saturation of 87% and very screwed up ABGs. So a pH of 7.21, a PaCO2 of 75, oh my gosh, that's high, and a PaO2 of 55, super low. Which immediate intervention is best? Okay, this is a best question here. So let's break this down. An elderly client with worsening COPD has an altered level of consciousness, so we know that's low oxygen, and a low oxygen saturation, which is to be expected. But here's the key numbers. You have to know your ABG numbers here, or they'll come to haunt you. So a pH of 7.21, that is way below 7.35. So our patient is very acidic. PaCO2 of 75, wow, that is way over the 45. So the patient is in extreme acidosis here. So we have high CO2, so I'm just thinking hypercapnic already. And a PaO2 of 55, that is way below 80, so hypoxemia. So we have high CO2 with hypercapnic. So the best intervention for hypercap is to give a BiPAP. Simple enough, right? Well, the client is going into hypercapnic respiratory failure. So option number 1 is incorrect. Applying oxygen would be the worst here. So no, for hypercap, we give a BiPAP. Now option 2, call the respiratory for stat albuterol. No, remember, hypercap, you got to give that BiPAP. Now option 3, our big long term for BiPAP. Yes, hypercap, give that BiPAP. Now option number 4, I know this one is tempting, but it's incorrect. Now for a big key term here is pursed lip breathing. This is when the lips are kept tight like blowing a kiss, and the goal here is for a prolonged exhalation or prolonged exhale. So why do we have clients do this, and why is it commonly tested? Well, let's explain in this next segment. Well, this helps to decrease the shortness of breath by keeping air inside the lungs, which prevents airway collapse and also prevents airway trapping. So Kaplan mentions purpose of pursed lip breathing, air trapping. And ATI also mentions pursed lip breathing is used to prevent airway collapse during expiration. Now, don't let the NCLEX trick you here. Pursed lip breathing does not help to thin secretions or even to cough up mucus. That is the huff coughing technique. And speaking of the huff coughing technique, this helps clients with COPD to effectively cough out or huff out thick mucus. And a few order response questions came up on various quiz banks. So write this down. The correct order for the huffing cough technique is number 1, sit upright in a chair with feet shoulder width apart and then lean forward. Number 2, key term here, is deep, slow inhalation through the mouth using the diaphragm muscle. And number 3, you need to hold the breath for 2 to 3 seconds and then forcefully exhale. And number 4, repeat the huff once or twice and avoid normal coughing. And then 5, rest for 5 to 10 normal breaths and repeat as needed until the secretions have cleared. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate. Now for the case study on COPD. So let's apply your knowledge with everything you learned here. So here we go. Miss W is a 60-year-old client with a history of smoking 3 packs per day for 30 years. She was diagnosed with COPD about 2 years ago and is being evaluated in the clinic today for worsening dyspnea, that shortness of breath. Upon assessment, the client appears tachypneic and reports intermittent productive cough. There's also evidence of clubbing in Miss W's fingers. Now, she's not going to the disco. Her fingers are clubbing here. Okay, always make sure you note the key terms here. And it looks like the client is suffering from that worsening COPD. So question 1, which is the priority assessment data for the nurse to collect first? Now, before you answer it, always consider the priority question. So think, what kills this patient fastest? In this case, COPD, that chronic obstruction, think chronic destruction of the lungs. So what lung assessment would you collect first? Think ABCs, airway, breathing, and then circulation. So in this case, breathing and oxygen levels are huge. So the correct answer, the client's O2 saturation, respiratory rate, and breath sounds. Again, remember the ABCs. Okay, the next question. Oxygen saturation is at 86% on room air. The respiratory rate is 32 breaths per minute, and labored and rhonchi are heard upon auscultation, or basically listening to the lungs. Okay, as you can see, that's a lot of keywords here showing evidence of worsening COPD. So the question, what additional data will the nurse assess for in a client with known emphysema? Now, always look at the key terms here. So the key term is emphysema. So think of the memory trick and the 4 test tips outlined in the video. These are huge key points, and they love to show up on Select All That Apply questions. So the correct answer here is increased AP, that lateral diameter, or basically barrel chest. So yes, look at the key term here is barrel chest. This reflects hyperinflated lungs. So look at the I in pink for increased chest, that barrel chest. As you know, clients have a loss of lung elasticity, which permits the chest wall to recoil to a position closer to total lung capacity position, thus increasing that chest diameter. The next answer is prolonged expiration from that air trapping. And the last one here is weight loss, which is a classic sign of emphysema. Now, question 3. What is the pathophysiological process responsible for dyspnea in clients with emphysema? Okay, this question is asking for the underlying patho for dyspnea, that shortness of breath, and difficulty breathing in emphysema. So again, in COPD, remember, chronic obstruction, think chronic destruction of the lungs, specifically with the elasticity of the alveoli, due to that long-term inflammation from smoking. This client smoked 3 packs per day for 30 years. Wowza, that is a lot of inflammation. So the correct answer, in clients with emphysema, the elasticity, key term, of the alveoli is lost due to the inflammatory destruction. The alveoli become permanently hyperinflated, making full exhalation very difficult due to air trapping. This is the rationale for prolonged expiration in these clients. Clients with emphysema will present with an initial report of dyspnea upon exertion that worsens as the disease progresses. So again, focus on the patho here before thinking of the signs and symptoms or manifestations, and it becomes a lot easier to connect the dots. Now, question 4. What is the pathophysiological process responsible for clubbing of the fingers in a client with emphysema? In COPD, that chronic obstruction, again, think chronic destruction of the lungs. And if the lungs are destroyed here, well, they can't exchange oxygen, right? So COPD, we see that low oxygen in the body, that hypoxia. So the correct answer, the chronic tissue hypoxia that accompanies emphysema decreases perfusion to the distal extremities. So to compensate for this decreased perfusion, the vessels in the fingers vasodilate, leading to additional volume within the fingers and manifesting as a clubbed appearance with those round fingernails. Now, question 5. What assessment data corresponds with a diagnosis of chronic bronchitis? Okay, the key term here is bronchitis. So for the assessment data, always think of the memory trick blue for bronchitis. So for the answers, pale bluish skin tones, known as cyanosis, productive cough with thick purulent sputum, and rhonchi, unusual lung sounds. Now, I call the rhonchi rumble as the lung sounds are heard when mucus and secretion rumble when breathing, indicating obstruction in the larger airways. Okay, now for the COPD practice questions. What is the pathophysiology of finger clubbing in clients with COPD? So go ahead and pause the screen and try your best to answer this question in about 60 seconds or less. Okay, let's break it down. Now, before looking at the answer options, you should always look at the key terms in the question first, and second, think of 1 to 2 things you know about those key terms. So this question's asking for pathophysiology of finger clubbing for clients with COPD. So the memory trick, think of the O's. Long-term hypoxia means vasodilated fingers, those clubbing fingers. As you know, the distal extremities have decreased perfusion. The vessels in the fingers vasodilate, leading to additional volume within the fingers, leading to that clubbing appearance. Okay, now looking at the answer options. Option A, peripheral vasodilation due to long-term hypoxia. So yes, this vasodilated fingers, clubbing fingers from that long-term hypoxia. So this is why the memory tricks are so very helpful. Now option B, central vasoconstriction due to CO2 retention. No, this is completely wrong. CO2 actually causes vasodilation to open up those vessels, not vasoconstriction, those closed vessels. Now moving on to C, air trapping within inelastic alveoli. No, this is not the cause of clubbing fingers. So always look at what the question is asking here. It's not asking for the patho of COPD and the lungs here. It's asking about finger clubbing. And D, changes in connective tissue due to alkalosis. No, again, this is wrong, but it's pretty interesting. In COPD, we have high CO2, that carbon dioxide, which we call carbon diacid for the memory trick. So the body goes into acidosis and not into alkalosis. And so therefore, this is incorrect. Now moving on to question 2. The nurse is assessing a client with a 30-year history of smoking with signs and symptoms of COPD. Which assessment finding would be most helpful in confirming a diagnosis of emphysema? Select all that apply. Okay, pause the screen. You got 60 seconds. Good luck. So here we go. Always look at the key terms first before looking at the answer options. And second, always think of 1 or 2 things that you know about those key terms. So for the key terms, 30-year history of smoking with signs and symptoms of COPD. Now the question is asking for an assessment finding for confirming the diagnosis of emphysema. So always think of 1 to 2 things that you know about emphysema assessment findings. So think of the memory trick PINK for pink puffer, and also the 4 test tips. Now I know it's a lot to remember here, but these are the key points that are vital to getting those select all that apply questions correct. Now let's look at those answer options. So option A, a productive cough. No, this is incorrect. Remember, the N in our PINK memory trick is for non-productive cough. Now, B and C are also incorrect here, as these are signs of blue bloater in bronchitis. So option B, that cyanotic skin, or basically that blue skin in blue bloater. And C, edema in the lower extremities. As you can see in the memory trick blue, B and E are the ones for blue bloater. We're looking for pink for that pink puffer and emphysema. Now the next 2 are correct here, D and E. So for D, a new onset of dyspnea at rest. This is one of our 4 test tips. And E, pink skin and pursed lip breathing. Yes, this is the P in the PINK memory trick. Now lastly, F, the wheezing and crackles in the lung bases. This is incorrect for the blue bloater with that fluid-filled lungs. So look at the U in the blue for unusual lung sounds, wheezes and crackles. Now again, I know it's a lot to remember, but this is why the key points and memory tricks are so important for the top tested information. Now moving on to question 3. When assessing a client for suspected chronic bronchitis, the nurse will question the client about which of the following. So once again, pause the screen and you got 60 seconds. So let's break it down here. Before looking at the options, number 1, look at the key terms in the question. So in this case, suspected chronic bronchitis. The nurse will question the client about which of the following. So number 2, think of 1 or 2 things that you know about those key terms. So always think of the memory trick BLUE for blue bloater in that chronic bronchitis. Now, option A, respiratory acidosis. No, this one is close if you were thinking about that low and slow gas exchange with acidosis, but this is true for both emphysema and bronchitis. Now B, clubbing of the fingers from hypoxia. No, this is incorrect. This is more true for emphysema. Now C, dyspnea while exercising. No, this can go for technically both conditions. And D, long-term productive cough. Yes, look at the L in the blue memory trick. L is for that long-term cough that is productive with sputum. Now moving on to question number 4. The nurse is teaching a new graduate about the pathophysiology of emphysema. What is the best explanation for prolonged expiration in these clients? So pause the screen and try your best to answer this question in about 60 seconds. Now before answering, once again, follow the question breakdown strategy. So number 1, key terms inside the question. These are pathophysiology of emphysema. And the question's asking for the best explanation for that prolonged expiration, basically breathing out. So once again, think of a few things you know about those key terms before looking at the answers. So use the memory trick PINK. P is for that pursed lip breathing needed to eliminate air trapping within the lungs. Okay, now let's look at the options. Option A prolonged expiration phase is necessary in order to eliminate air that is trapped within the alveoli that have lost their elasticity. Yes, the key term here is eliminate air trapping within the alveoli that has been destroyed, losing its elasticity. So remember, COPD, that chronic obstruction, means chronic destruction of the lungs. Now, B is incorrect because prolonged expiration helps to eliminate excess secretions that build up in the bronchi. No, way incorrect. A huffing cough would actually help eliminate secretions, not a low and slow prolonged exhalation. Clients need a big forceful cough to get that lung butter out of the body here. Now, option C is incorrect. A long exhalation is necessary for clients to protect against chronic acidosis. Now, this one was close, but it's incorrect. Acidosis comes from too much CO2, that carbon dioxide, which we call carbon diacid. But the purpose of pursed lip breathing is to keep the airway open and prevent that air trapping. Now, option D is also incorrect because prolonged exhalations are a compensatory mechanism for respiratory acidosis. No, again, this is another close one, but it's incorrect. A compensatory mechanism for acidosis would actually be to breathe faster and not slower, to push the body into that alkalosis, kind of like panting like a dog. So once again, the purpose of pursed lip breathing is to keep that airway open and prevent air trapping. Now the last question here, number 5. What is the best explanation for the pathophysiology of polycythemia with clients in chronic bronchitis? So pause the screen and try your best to answer this question in 60 seconds or less. Okay, you know the routine, let's break it down. Number 1, look for the key terms before looking at the answer options. So the question's asking for the best explanation for polycythemia, that key term, in clients with chronic bronchitis. So once again, think of 1 or 2 things you know about those key terms. So for polycythemia, even if you don't know what the word meant, just let the name help you here. Poly means a lot, and emia means blood. So basically, a lot of blood. With clients in chronic bronchitis, where we have that low oxygen inside the blood, that hypoxemia. So why should the blood, or body rather, produce a lot of blood? Well, we know that the RBCs, the red blood cells, carry oxygen around the body, right? And in COPD, we have low oxygen, that hypoxemia. So the body produces those RBCs, or red blood cells, at an exponential rate, in hopes of carrying more oxygen around the body to compensate for that low oxygen within the blood. So option A, increased red blood cell production to compensate for acidosis. No, this is incorrect. It's not compensating for acidosis. It's compensating for that low oxygen, that hypoxemia. Now B, increased red blood cell production in response to prolonged hypoxemia. Yes, we're compensating for the low blood oxygen, that hypoxemia. Now the last 2 here are incorrect. For option C, decreased red blood cell production in order to prevent formation of blood clots. No, we're looking for increased RBC production. And D, decreased red blood cell production due to bone marrow dysfunction. No, once again, we're not having decreased RBCs, but rather increased. So remember, if one part of the answer is wrong, then the whole option is wrong. So we have increased RBCs in polycythemia. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos.